Good afternoon, everyone. Today I'll be presenting a rare case report on Goldenhar syndrome. It is a rare case. I'm reporting a rare case of 8-month-old boy presenting in our OPD with limbal dermoid encroaching over the cornea in the right eye associated with ear tag on the ipsilateral side and with scoliosis suspected to have Goldenhar syndrome. It is a birth defect resulting from malformation of first two brachial arches, which lead to incomplete development of ear, nose, soft palate, lip, and mandible. It is also known as oculo-auriculovertebral dysplasia, which has limbal dermoid, preauricular tags, hemifacial asymmetry, and vertebral anomalies. It is usually unilateral, and it occurs in 1 to 3,500 to 1 in 7,000 live births, and the male to female ratio is 3:2. Now, in my case report, it's an 8-month-old patient who was brought into the ophthalmology department by parents with a complaint of mass in the right eye with associated preauricular tag present in the right ear since birth. The child was a full-term normal delivery, and there was no history of any maternal illness during the pregnancy. He was a first-born child from a non-consanguineous marriage with uneventful prenatal antenatal period with no drug allergy or known medical history. All the other family members were normal. On my ophthalmological examination, a mass was present on the limbus from 7 to 9 o'clock position, encroaching the cornea and gradually increasing in size. The mass was whitish pinkish in color with well-defined margins, firm in consistency, and it was circular with 2 into 2 mm size, and it was non-compressible. The mass was adherent to the underlying cornea and sclera. Rest of the anterior segment examination came out to be normal. The fundus examination was normal. Now, there was a multidisciplinary approach taken by all the departments. When the patient was sent to the ENT for ENT examination, there was an ipsilateral ear tag present on the same side with no other abnormality in the ear. The patient was then referred to the pediatrics department, and no other systemic abnormality was diagnosed. Then next, the radiological investigation when done, X-ray revealed vertebral column scoliosis. Now, there are different differential diagnoses were seen. First being the Goldenhar, second being the Treacher-Collins syndrome, third being the Townes-Brocks syndrome, fourth being the linear nevus sebaceous of Jedison, and fourth being the Chard syndrome. But based on the clinical and radiological findings, diagnosis of Goldenhar syndrome was made. Now, the treatment was given. It was the limbal dermoid. It was excised, and then the amniotic graft was sutured upon the bare conjunctiva, so as to prevent the development of amblyopia, and also the induced astigmatism caused by the corneal structure abnormality, to reduce it. So we excised the limbal dermoid. On histopathological report when sent, it showed squamous epithelium and sebaceous glands in the specimen, giving impression of limbal dermoid. Preauricular tag was removed by the ENT department. Scoliosis was managed by the orthopedicians by giving a Milwaukee brace, and the child was kept on the regular follow-up after surgery to look for post-op complication. This is the ear tag, this is the limbal dermoid, and this is the X-ray showing the scoliosis. Now, in my discussion, I would like to say that the ocular manifestations in Goldenhar can be limbal dermoid or lipodermoid. Limbal dermoid being more common, and it is usually present in 25% of the cases in the inferior temporal quadrant. There are two types, large and small. The large one interferes with the visual axis, causing astigmatism and predisposing to secondary strabismus from anisometropic amblyopia. Now, the other findings that can be included are hemifacial asymmetry, microtia, macrosomia, and mandibular anomalies. Now, the treatment of the disease varies according to the severity of the manifestation. With regard to the rule of ophthalmology, is aimed first at the risk causing obstruction of visual axis, severe astigmatism or strabismus. Second, we see for the ocular exposure due to the large coloboma or large limbal dermoid preventing the lid closure. Now, treatment of the condition related to large coloboma requires surgical repair. It should be removed, excised with limbular keratoplasty. Now, to conclude my case, I would like to say that it's a rare congenital abnormality associated with cosmetically unacceptable defects, whose management may pose numerous challenges. This case has been presented to increase the awareness of this rare entity, and it was a challenging one as Goldenhar needs multidisciplinary approach and a high degree of suspicion. We should always rule out other congenital abnormalities. This is the bibliography. Thank you.
Thank you. May I please have your name? Dr.
Mehakleen.
Mehakleen. Okay, that was a nice presentation. Congratulations on the presentation. Just one point would like to make is that your screen, the PPT, should be a little more visible. Like the background, it was a little difficult.
Ma'am, actually, I had a different background. I don't know why when I presented it.
Okay, no problem. Now you said that it is a rare presentation. Why do you feel that it is a rare presentation?
Ma'am, otherwise, when we see in the history, it's 1 in 3,500 to 7,000 births. And in my 2 years of experience as a GR, I have just seen 2 cases. One which I've reported and other one I cannot follow up.
Okay. Although it is very rare, but we do find this birth defects, and it was well managed. That is good. But sometimes we also may have, for your information, I'm saying that we can have microsomia of one side, and that also might require your palatal, reconstruction in certain patients, and sometimes you may have more than one dermoid also in the eye. So that also requires aggressive as well as very early treatment from the cornea department. Okay. So that was really nice. Take care of the dry eye part in these patients on follow-up.
Yes, ma'am. Okay, ma'am. Thank you, ma'am.
Thank you so much.
Thank you, Dr. Mehaklien. I would also just like to add that these cases demonstrate how we as orbital surgeons really need to be in close contact with, say, the cornea surgeon, ENT surgeon. We really need to have a very good, network to help.